Those are an example of contact dermatitis is like a diaper rash, that time of thing. You're in contact, so you're going to have, it's going to create a skin breakdown. Seborrheic it has to do with oil glands, and you're going to see that on the head, cradle cap, things like that. And then psoriasis is usually associated, it's usually really well demarcated around the edges, and it's usually the terms are usually plaque psoriasis. And, you know, when somebody has psoriasis a lot of times you're going to put steroids on these things to try to make them go away. But if it's on the face or it's covering a very large area, then you're going to think about doing oral. You know, if you don't want to put a strong steroid on the face, and then psoriasis is actually an autoimmune problem. And so you've seen those biologics that they have on the commercials on TV, and you know the risks of them are TB, death, everything in the world. So you know it's got to be pretty severe, I think, psoriasis to go for any of those drugs. But that would be my opinion. So you have itching. Itching is usually a manifestation. It can be renal. It can be just about anything, right?
Yeah.
Okay, paronychia. Have y'all seen toenails in the clinic this semester? Anybody seen one removed?
Several.
Yeah. And in fact, my son said to me the other day, he said, I hope I never get an ingrown toenail, because I guess his friend had one and he was really appalled at what they did to him. So what did you see? And you just saw them, did they just inject under the nail and then cut it off with scissors, or how did they remove it?
We did a block for the whole toe, the entire toe, and then we would do a wedge.
Okay. Well, what are you calling a wedge? What's that?
Just the outside of the toenail in like a pie shape in a wedge.
Yeah, like with scissors. Did they use scissors just to cut it off, or how did they do it?
It was I can't remember what he called them. It's a special kind of scissors they were flat on the bottom, and then they cut on the top so you could get underneath the nail to cut it, and then make sure you got underneath all of them.
Okay, good. So, and I've seen them remove the whole thing, and I've seen them removed, you know, just what you're calling the wedge, right? So, but, you know, that's patient teaching, and that's really a procedure. You know, the teaching is don't trim the toenail below the edge, you know, below the top of the toe. You want to keep it grown out so it can't grow into the edge. You want to keep it straight. Don't curve it. You know, that nowadays you see women with these toenails that have they're doing a French manicure on the toenail, so you know they're plenty long enough.
Yeah.
Okay, so animal bites, you're going to be giving antibiotics for those, right? And are we going to do any kind of tetanus shot? What are we going to do for the animal bites? Dog bites, are those going to have the real puncture? Dogs tend to grab and tear. So, you know, they can be serious, but in cats, you're definitely going to give antibiotics and this. So just kind of review the antibiotics. It's mainly dog and cat. They'll get into this, and don't worry about wound closure. You're going to want to be able to see your patient in the clinic, know if it's something serious, you know, if you could handle there, or if you need to send them out, and then give them their antibiotics and their tetanus. That's really what you need to do. But wound closure, we're really not going to go, you know, we're not going to test that, right, unless we have a clinic on that. Psoriasis, rosacea, did y'all study that at all? Let's see, let's find what, isn't that, it looks like a Christmas tree. Is it a Christmas tree pattern?
Yeah.
Okay. Cases, we've got that, and usually on the boards, what they're looking for is if you can recognize it, and then, you know, and then have some idea of what, you know, patient teaching, things like that. But what I saw when I was tested was those, you know, Christmas tree patterns, herald patches, and they might also show a picture. Okay, so just be familiar with that. And alopecia, I never saw anything on alopecia on my board. So there's not a lot to do about that, right? You maybe think of differentials to do with alopecia and steroids, even steroid shampoos. I've seen them doing that. People will have some alopecia, you know, when they're pregnant, the hair, all the growth of the hair, it kind of sinks up so that they're not losing hair while they're pregnant, and that all of these follicles kind of get synced so that after they deliver, then they tend to lose some hair because of the hair cycle. And then, but you want to look for, you know, you want to think about hypothyroidism, things like that. You're going to look at male pattern, you know, hair loss, things like that, even in female. Okay, so you're going to look at hair pulling, things like that. But, you know, that's not, I don't think that's real, you know, just like that. That's not one of the critical things that I would see tested on your boards, but it's important to know. I had a lady one time, actually, believe it or not, she comes into the clinic and she had a, whose dog is barking? My dog is still barking if you keep it up. She had a poster board. You can mute your microphone if you have the dog. She had a poster board, and she had lines drawn on it, and she had hair glued into each place on like 10 different sections. And she had pulled it out of her drain and glued it on this thing to prove that she was losing hair every day. Well, she was losing hair. She was insisting she had hypothyroidism, and she did have it, but she was treated, and she was euthyroid. But she was losing in this male pattern, and you know, we asked her, she was 75 or so, she was up there, and we asked her, you know, did anybody else in your family have it? And sure enough, it was familial. Other people in her family had the same problem. So, you know, think about that when you look for male patterns, baldness, even in females, and then okay. So as far as dermatology, you can see that there's probably going to be about 17 questions, and the majority of them are on dermatitis, recognizing the skin cancers, and, you know, malignant melanoma. Everybody knows. I found a melanoma risk, and there's another one that they use. It's like Glasgow 7 or something, but I thought this one was kind of cool, from the National Cancer Institute. And it goes to the south. You know, you can say, I did me, light skin, lightly tan, 5 to 11, and then it calculates your risk. So absolute risk is 0.35%. An average of 3.5 people will develop melanoma out of 1,000 women living in this region. So, you know, I think that, you know, knowing who's at risk for it. And, you know, if melanoma, you know, you want to protect the skin is one of the main things, protect it from the sun, and look for those, you know, variations in the types of lesions, that they're going to have abnormal borders, they're going to be changing, they may have some sensation and tingling, itching, those things. Know which one is most frequent, you know, what you're going to see most often, and those things, and the difference between just a keratosis and a carcinoma. Okay, and so there's going to be 3 questions on skin cancers, and then acne, and you can expect, you know, some meds on there and that type of thing. Okay, so GI system, we kind of had a review over the GI system, but I don't know if you have additional questions. What we talked about before was a little bit, it was kind of brief, and so I just thought that we could go over a couple things. Did y'all have any questions about the GI system or any areas of weakness that you were concerned about?
So one question I have is, what about hepatitis C?
Uh-huh.
Just that, you know, there's that new medication
that new medication that it's saying that there's 96 to 99% that it can cure hepatitis C if it's genotype 1. Would any of that be on this test, or is it
No.
something that we should be
No.
worried about?
That's specialty care.
Okay.
Yeah, I wouldn't go. The main thing that you're going to see, if you look in any of the review books, what you're going to see is diagnosis. You're going to look for risk factors. You're going to look at transmission and the labs, and, you know, how long are they going to be sick. And, you know, I looked up the hepatitis B one, and it usually clears, the acute symptoms usually clear in a couple of weeks, but it can take up to 6 months. So that's why I was a little confused on that. But it can take up to 6 months for acute symptoms to really go away. And if you look at they have all these some pretty good stuff in hepatitis B infection. You know, they show all the little tests and stuff. But I thought we might go over the testing if you wanted to look at that a little bit, because that, did y'all learn it really well? It's, it's one of those things that you kind of learn and then you forget, and you learn and forget again. But I know there's some ways to learn it, but we'll talk a little bit about, kind of doing a few little, read some tests and see how they go. But ALT and AST, I know you've probably seen this, that if the ratio is greater, ALT to AST is greater than 1, then think viral hepatitis. And I don't know what the heck that means, right? So, well, maybe I know a little bit, but if I were going to want to know what this is how you explain it, is that, if you have a ratio of ALT to AST, you're going to put ALT over AST. You're going to divide it by. So you guys are probably recent enough with your education that you don't need to remind yourself of that. But so you're going to separate. If you have a ratio of 140 to 88, you're going to put 140 over 88, and then you're going to get your number. So you would see in here that ALT ratio to AST, that means ALT divided by AST is greater than 1. So that would mean that ALT had to be more. ALT is higher than AST. And sometimes people remember that by the L for liver, problem with the liver. And you can associate that with, a liver inflammation or hepatitis. That's just a memory trick. And then the opposite is true for AST is greater than ALT, and the ratio is greater than 2. And that usually is drugs and alcohol, acetaminophen, statins, alcohol, things like that. So you're going to see those, and we talked a little bit about the non-alcoholic cirrhosis and things like that. And you're going to see in the fatty liver, you're going to see those kind of enzymes elevated, and that is hepatitis, non-steatohepatitis. So that you're going to say you would expect the ALT to be higher than the AST. So when you see that ratio, just think it's greater than, it's higher, but it has to be a certain amount higher. So does that make sense to y'all? I think so. Yeah, it's just a way of looking at those lab tests that if you see the S, think statin. I would say when I see the S, I think statin, and then I just think drugs. It could be alcohol, that type of thing. But statin, I think it's something acting upon the liver like a statin. And then when I think of ALT, I think it's the actual liver or inflammation of the liver. So I pulled a couple of questions. Colon sign is most commonly associated with which problem? Y'all know what colon sign is?
Pancreatitis.
Yeah, that's the correct answer. It's where you have that little yellowish blue coloration around the belly button. Mm-hmm. And it's because the pancreatic enzymes may run along that ligament. So that was just one of them. And then diverticulitis. Okay, this is talking about antibiotics. The reason we want to know what type of organism is because we want to know what antibiotic to treat them with. And so, you know, you'll see some broad spectrum stuff going on, but do y'all know, this is a trick question, so don't feel like you can, don't feel like you have to know the answer, but diverticulitis is most often infected with which type of organism? Now you're going to think about the gut, right? What's the obvious organism in the gut that you can become infected with? The E. coli, right? E. coli, and that's gram-negative. So we're sure there's going to be gram-negative. But in the literature, what it says is anaerobic microorganism, anaerobic organism. So I'm like, which ones are anaerobic? Because I'm not quite sure. MRSA, no, and Streptococcus, maybe, right? What's anaerobic? But if you look right here, I printed out, I copy and pasted some anaerobic. So you have gram-negative and gram-positive anaerobes. Okay, but diverticulitis is associated with gram-negative most often. That's what we think of because it's the gut, and we always think of, you know, below the waist is gram-negative and above the waist is gram-positive. But you can see that in the diverticulitis, it's going to be anaerobic, so it'll be gram-positive and gram-negative. So the reason that was kind of a trick question is because both of these are right. But they're saying anaerobic. So those are the terms that you're going to read. And from what if you look at the treatment for diverticulitis, not all diverticulitis needs antibiotics. You know, some of it can just be clear liquids and, you know, rest your gut and things like that. But if you do decide to do an antibiotic as an outpatient, you're going to look at Cipro, and you can see, and I always have to look again. So Cipro is gram-negative and a weak gram-positive. And then you have metronidazole, so you're giving 2 drugs. And what you're saying is that is a broad spectrum. You're going to go broad spectrum. Amoxicillin, the augmentin is gram-positive and gram-negative and beta-lactamase. So this is a broad spectrum. It's one drug, right? And so then you have maybe some allergies. But I just kind of wanted to show you that know that not all diverticulitis needs antibiotics, but you'll probably see them given, you know, but it depends on the patient condition. And, you know, some of them need hospitalization and some of them don't. So that was kind of I promised there won't be any tricks on the test, right? No tricks for you. Okay. So now that the hepatitis testing, and I put in the soft chalk. Let me find the hepatitis one. I put a little chart, and I know y'all did some charts too. Which one is it? This is part 1. Is this part 2?
Yeah, part 2.
Yeah, let's see. Oh, it keeps going. Okay. Sorry, it keeps, you know, it's every time I go up to the top, it pulls something else down. Let me see if I can get it. Oop, there we go. Okay, part 1, and then we're going to go to, let's see if I've got hepatitis. There we go. Okay, so some of y'all may have listened to, how many people listened to Amelie's lecture on this? Do y'all listen to that at all? Amelie Hollier, APEA, she has those, I think some of y'all might be going to a review session soon or maybe wait till next year. But her disc, she does a really good job of explaining this, and I like the way she does it. But let's think about what most of the questions that you're going to get questions on the boards like, how is hepatitis A transmitted? You know, that's fecal oral route, right? And so you're going to get some questions on hepatitis C, and a lot of what they're going to talk about is the chronic hepatitis C and the risk and how do you know if it's become chronic, you know, what are the lab values to show if it's chronic. And then what are the risks of it, for cancer, things like that? How does it, and I have a patient right now who is converted over. He had hepatitis C, and he has cirrhosis, and he has liver cancer. So he has all three, and he's doing okay. He's still alive, so he's not too old, so he may get there. But so the antigen, the surface antigen, if you think of hepatitis as being a viral, let's say it's a viral. I wish I could draw. I should have drawn it for you. I don't think I can. I would have to figure that out. But it's a virus, and it's picture it as a round virus, and a surface antigen is something that's on the surface of that circle. Okay, so this is actually the virus. When there is something on the AG antigen, when it's on the surface of the virus, it's infected. Somebody's infected with it. AG means they're infected. It's the virus. But when you have an AB, that's an antibody. And you know that your body produces antibodies to fight infection. And so that's your response to it. Okay, so if you're thinking about, if you see these, so the H is hepatitis, the B is the type of hepatitis, and then you got surface antigens, those are on the surface of the virus, and then you have surface antibodies and core antibodies. Well, if you have a core antibody, that means that the antibodies are all the way into the core of the cell, and it's a marker for an acute, chronic, or resolved hepatitis B. It's not immunity from an immunization. So hepatitis core means you had the infection because it got all the way into the cell. Think of it that way. And it may not be, what I'm doing is giving you memory tricks. I'm not giving you, really a pathophysiological lecture. I'm trying to help you remember what these values mean. Okay, so you have hepatitis B surface antibody, and that means that you're immune. So somebody that's had an immunization, this is what you would expect to be positive, but you would expect the antigen to be negative because they don't have the virus, and you would expect the core antibody to be negative because they never had an infection. They just have immunity. So, and you're looking at this IgG, that means that it's post-exposure, and IgM means that, and I've heard miserable. IgM, M means miserable. That means that they have it now. Wait.
No.
That's what I remember. Would I type it wrong?
M is minute, G is gone.
G is gone. M is what?
Minute. You have it right now.
Yeah. Okay. I think that's what I said. I'm not sure if I typed it right, but I'm not reading. I'm talking. But anyway, I saw this right here. This is anti-HI. So, but yeah. M for miserable, M for minute, you can do that. So you've got some little memory tricks here. And I think it's important to, at least get these things in right here. The hepatitis B surface antigen, hepatitis B surface antibody, hepatitis B core antibody. To really understand those, and you can apply them to hepatitis C. You know what I mean? If you just take hepatitis C surface antigen, hepatitis C surface antibody. So if you understand what these little letters mean, then you can think your way through it. Okay, hopefully. So let's think our way through a couple if we can. Hopefully I can help you with this. Okay, so we have hepatitis B surface antigen is negative. So the surface antigen means that right now, there's antigens on there. So that's the virus. That's the virus on the cell. Okay, so that's negative. Now we have hepatitis B surface antibody negative. So we know that that means that they're not immune, right? And we hepatitis core antibodies negative. They never had an infection. So this person is not sick now, not immune, and never been sick. So we would want that person to be immunized for hepatitis B. This is somebody you would recommend immunization for. And so let's go to the next one. You go hepatitis B surface antigen negative. That means that there's no virus on the cell right now. Hepatitis surface antibody is positive, and we already talked about this. This is the one where can you see what's going on here? What would you think about this person?
They have immunity to the vaccine.
They've never had the disease, right? But they're immune from an immunization. Okay. So let me see if I can find. Let me find one more. Let me see. Okay. So let's say that you have hepatitis B surface antigen is negative, and hepatitis B surface antibody is positive. So this one right here is positive, and now this one is also positive. What would you think this person has? Do you think they're sick right now?
No, he's been immunized for C and...
Yeah.
Well, but we've got hepatitis core antibody is positive. So that means that at some point he had
it, his own immunity.
Yeah, he produced his own immunity.
Mm-hmm.
Can you see how that, so this is a core, that means that the antibody got all the way in, and that means he was sick. If it went to the core, he was sick to the core. Okay? But if he's, and then this, he's probably immune because he had the disease. He produced his own immunity. Okay? And I'm not going to, you can look at chronic infection. When somebody has hepatitis surface antigen is positive over a long period of time, that it stays positive, and there's no immunity, and they have this the core is positive. That a core positive can mean that they had it before or they have it now, either one. But it's over the length of time. So think of time, and I would have to look up what the time frame is, but I think at this point, just know that it's over a period of time. That you expect it to go away, right? We know that acute symptoms can last, several weeks or up to 6 months.
Yeah.
So just think of it in those terms, and you will learn more as you go through. You know what I mean? You're gonna have a chance to apply these things, and I would recommend that you do that. But right now, what we're doing is we're doing sort of a little, giving you an introduction and a license to learn. I know Dr. Miller covered some of this in infectious disease, right? Did y'all go over any of this in infectious disease? So it's a little bit of a review, maybe. Okay, so what time is it? We still have a little time. Any questions? These are kind of like just like the basics, some memory tricks. And if you have questions, I will try to answer them. I know what I know, and I can always look it up. I'm not the encyclopedia, but I can give it a try. Okay, so I have a few flashcards. Okay? So they're over different topics. They're not all over hepatitis, but they're just kind of general GI flashcards. I don't think I had any. I might have put some in there for, let me see if I did any Derm flashcards. No, I don't see any. When I told you when I was in my program, I made about 1,000 flashcards. So I was prepared. Okay, so where my flashcards go? Here we go. Hyperbilirubinemia can cause what? So it has to do with protein-bound drugs. okay? I don't think you're going to see that, but, you know, that's something to think about. If you have somebody with a lot of bilirubin in their blood, then it's going to be a problem of protein-bound drugs, and you're seeing cola-colored urine. And that's what we would expect, right? In diarrhea, what signs suggest a viral cause? Everybody should know this, right? What is it? If you have a patient with diarrhea or gastroenteritis, what would you think is a viral cause? Fever.
Fever, yeah.
That's too easy, right? You're thinking, what is it? What is it? No, it's just fever. It's not that. It was too easy. Okay, so, and I think that GI, people do pretty well on this test because it is very familiar. Yeah, I think people are pretty familiar with GI stuff. Maybe not so much derm, and it's not my strong suit either. But I think Dr. Miller gave you quite a few little quizzes and stuff. So who should be immunized against hepatitis A?
People that are traveling to third world countries or...
Has this changed? Don't we give this to babies now? Don't children get it? Don't we just give hepatitis A to everybody now?
Yeah.
It seems like, you know, that flashcard might be kind of old. My flashcard says, you know, probably what you said is food handlers, travel and daycare workers, lab workers, IV drug use, and all patients with hepatitis. But did y'all study the immunization schedules? Let's see.
It was
Hepatitis A.
Hepatitis B was.
Not hepatitis A is not on there?
I thought it was just B, but I don't.
Yeah, because B was the first one.
Okay, good. Okay, immunizations for children. And
A is down the road, 12 months.
Oh, here, hepatitis A down here.
is it there? Oh my goodness, it is. So my flashcard, I didn't publish these for y'all because they were a few years old, but you can see that, you know, that, and there's a little...
Yeah, they get it at a year.
And I just hate that. I mean, from my perspective, I just hate filling these kids full of holes. But, you know, if they're not going to be exposed, why are we doing it? But that's just my opinion. I'm not against immunizations. I love them, but
Kids go to daycare nowadays, so.
for daycare, oh yeah, because it's oral fecal. Yeah, that's true. That's a good point. And, you know, I teach a TB in the next class. In the fall, we talk about TB. And I was like, why are we spending all this time on TB? Nobody has it. and then one of my faculty members said, here, read this book. So it was about the worldwide, you know, fight against TB and how, you know, the Texas border, we're really holding the line. So, you know, I guess you know, it's good that I have young minds here to think about these things because daycare it's fecal to oral, right? So that's really important. But I guess if I think of no risk in that age, but there is risk. So don't listen to me. I'm going to cut that out of this recording, so I do not have said it. Okay. All right. In acute hepatitis A infection, expect AST to be greater or lower than ALT. So we're talking about hepatitis. Hepatitis, is that a statin? It's a liver thing, right?
That's the liver, so the ALT would be higher than the AST.
Right, so I would expect AST to be lower, but let's see if I got it right. AST to be greater than, that's not right. That flashcard's wrong. I think that's wrong.
Yeah, it is
I
wrong.
think your ALT is going to, so you see you learn more from a bad card than a good one. Okay, so Murphy's sign can be elicited by, you all know that one, right? It's where they take a breath.
Quadrant.
Yeah. And when they release their breath, right? They release, blow it out, then you push, and it'll cause them to try to breathe. You know, they'll gasp, right? And that's for coli, right?
Right.
Okay, symptoms of GERD, too easy. chest pain at rest, postprandial fullness, chronic hoarseness, nocturnal cough, wheeze, sore throat, that type of thing. Okay, most common cause, we've talked about that a lot, contaminated water supply. Hepatitis A infection, contaminated water supply, okay. Is an active and it requires, okay, so they're asking what kind of immunization is it an active or an inactive virus? Immunization, so it's inactive. Okay. In GERD, a proton pump inhibitor is prescribed in order to raise gastric pH level. So that's asking, do you know if pH is higher or lower? You know, if you want to kind of reduce acidity. Base is higher, acid is lower. Okay, so a positive hepatitis B surface antigen means what? So we know the antigen is what?
That's the virus.
That's the virus. So let me, currently infected with, oh, y'all are so smart. There we go. Okay. So we got a patient with an AST of 22, which is normal, an ALT of 25, which is normal, and an HAV IgG positive. What does that indicate?
They have the disease, but it's gone.
Resolved hepatitis A infection. Okay, so they're not sick. Their liver enzymes are fine, but they had it in the past. And, you know, have y'all run any hepatitis panels? Have y'all seen hepatitis panels?
Yes.
No.
I've had a couple of positive hep C's in my clinic.
Okay, and did you get the IgG and IgM and all that stuff on your panel?
Or after they were positive on the hep C.
So you're going to get more than just those three, the surface antigen, the core antibody, the surface antibody. You're going to get the IgG and the IgM. If you do a hepatitis panel, you're going to get those two. So G means gone, and M means minute or miserable, right? Okay. In a patient with severe GERD, what other symptoms might the patient report? Oh, this is just sore throat. Yeah, sore throat. That could be anything, but, you know, that's why I told you the answer. Most common reason for a liver transplant?
It doesn't work. Oh, hepatitis C.
Hepatitis C. There you go. We talked about that before. Larry Hagman, right, got one. Okay. In statins, you expect a slight rise in AST. True or false?
Yes, true.
Yes.
Yep. There you go. You guys got it. Okay. Which cardiac drug exacerbates GERD? Who knows, right? Anybody know?
Anything that any kind of relaxer.
Yep, you got it. I think you're right. A calcium
Panel blocker?
Channel blocker.
channel blocker. Yeah, you're right. Because it would relax that valve or whatever. What drug history do you suspect in a patient with erosive gastritis? What's the biggest thing that and say, yeah. Yeah. So, you know, H. pylori, you're gonna want to know, you know, what's the cocktail that you're gonna give them for H. pylori. When I remembered it, I didn't remember the specific antibiotics. I just remembered that I was going to give a PPI, an antibiotic, and, you know, I remembered, you know, kind of the drug classes. And then because there's different ones, and then they say if they're allergic to this and allergic to that. So I think if you know kind of the cocktail, the first line cocktail, you'll be okay. But if you have somebody with erosive with gastritis symptoms, GERD symptoms, you can test for H. pylori. And, you know, when you're looking at peptic ulcer disease, peptic ulcers occur in the stomach and in the duodenum or duodenum, however you want to say it. So that was the one where, you know, when the stomach is empty, it's going to hurt. When you eat food, you know, like you eat food, and then after the food clears and the acid's able to get to the lining, that's when it hurts. So I hope you remember those kind of little memory tips. Okay, so we're almost out of time. And I think just kind of go through these go through these little soft chalk lessons and just, you know, review the assigned readings, and I think you'll do fine on our test coming up. Okay.
Did you, with Dr. Miller being sick, did you write the Derm questions, or did he?
No, he wrote them.
Is he doing okay?
Yeah, he did. He's at home and he's recovering, and so but he won't be back this semester. But I think he's going to teach this summer, but not in acute and chronic 1. He's going to be teaching fawn this summer.
Okay.
So, yeah, so we're all, you know, rooting for him to feel better and get well, and so. But I hope you don't feel like that you're at a loss on the Derm. Especially since I spelled it wrong. So, but we tried to, Dr. Bray and I kind of tried to make sure that, you know, that everything that you read was what was tested on and all those type of things, because I think, you know, Dr. Miller probably would have done a little more review and things, so we wanted to make sure that you had a fair chance at it, and the test was fair, so we think it is, so. All right, so that's it, and don't hesitate to ask questions. You know, if you have concerns or whatnot, just don't hesitate to call on me. Okay?
Okay.
All right. Thank you. Bye bye.
Thank you, ma'am.